Peripheral neuropathy and fall risk. Patients with peripheral neuropathy exhibit an increased risk of falls. Those with diabetic polyneuropathy demonstrate greater body sway during quiet standing compared to healthy individuals. Notably, this increased sway occurs not only with eyes closed but also with eyes open, suggesting that visual input cannot fully compensate for the impaired somatosensory function. However, body sway is not universally elevated in all neuropathies. For instance, patients with Charcot-Marie-Tooth disease type 1A, CMT1A, show minimal changes in postural sway. This may be attributed to the fact that CMT1A primarily involves axonal demyelination and the loss of large-diameter myelinated nerve fibers, including IA afferent fibers. In contrast, diabetic neuropathy often affects small and medium-sized afferent fibers in addition to large ones, leading to sensoromotor distal symmetric polyneuropathy. Thus, the heightened body sway observed in diabetic patients during quiet standing may stem from the involvement of medium-sized spindle group 2 afferent fibers alongside group IA fibers. This implies that signals from length-sensitive spindle secondary endings, group 2, may be more effective than those from primary endings, group IA, in detecting slow shifts in leg muscle length caused by displacements of the body's center of mass during stance. Interestingly, some studies report increased sway in CMT1A patients, possibly due to advanced disease stages where severe demyelination and axonal loss may also affect smaller afferent fibers. Additionally, individuals with neuropathy exhibit delayed muscle response latencies to postural perturbations and impaired ability to adjust postural torque in proportion to perturbation velocity and amplitude. Patients with sensory neuron disease, SND, characterized by the loss of dorsal root ganglion neurons, experience severe ataxia. These individuals display marked instability during quiet standing, even with eyes open, unlike typical sensory ataxia, where balance worsens only with eye closure. This underscores the critical role of somatosensory input in facilitating optimal visual integration for balance control. Furthermore, SND patients exhibit delayed postural response latencies, particularly in long loop, presumably supraspinal, reflexes, suggesting that their balance deficits arise primarily from the loss of central afferent projections. Postural instability in SND is significantly more severe than in peripheral neuropathy. Similarly, patients with cervical spondylotic myelopathy demonstrate pronounced body sway during quiet stance and delayed late responses to postural perturbations, likely due to dysfunction in spinal sensory pathways relaying information to supraspinal centers. Despite their increased sway during quiet standing, diabetic neuropathy patients maintain relatively normal anterior-posterior body displacement when exposed to predictable platform perturbations. This may reflect their retained ability to utilize anticipatory postural adjustments, APAs, in dynamic conditions or an increased reliance on vestibular input for generating APAs. In contrast, SND patients perform poorly even on predictably moving platforms, likely due to impaired long-loop pathway function.